Good morning, and welcome to today's program titled Advances in Prostate Cancer Screening and Management, presented by Northwestern University Feinberg School of Medicine at OMLive. You are tuned into the first live session, Beyond the PSA, Emerging Biomarkers for Prostate Cancer Screening with Dr. Bill Catalona. My name is Dr. Tony Schaeffer. I'm the chairman of the Department of Urology at Northwestern University Feinberg School of Medicine and co-chair of this educational program. Today's sessions are live and are meant to be interactive. We will be taking your questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them into the box located on the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Bill Catalona, professor in urology at Northwestern University Feinberg School of Medicine. In addition, Dr. Catalona is the director of the Clinical Prostate Cancer Program of Northwestern's Robert H. Lurie Comprehensive Cancer Center. Dr. Catalona developed the PSA and is internationally known for his work in prostate cancer detection, screening, and management. Welcome, Bill. I'd now like to hand the program over to you.
Thank you, Tony. This program is really based on a conference that was held about a month ago in Bethesda, Maryland, the NCI SPORE and Society of Urologic Oncology workshop on biomarkers of prostate cancer aggressiveness. And in this conference, each biomarker was discussed by a presenter and by a critical discussant and then reviewed by a panel. And I've tried to summarize the results of this conference. In the way of full disclosure, I'd like to point out that my research has been supported by manufacturers of PSA and manufacturers of prostate cancer genetics studies. We're going to focus in two areas on biomarkers. First, in general, we're going to be talking about biomarkers in the early detection and pre-treatment phases of clinically localized prostate cancer. And we're going to break these biomarkers down into two topics. One will be those that are used before the biopsy, and then we'll have a discussion of these, and then we'll discuss those that are used after the biopsy and after the diagnosis of prostate cancer has been evaluated. So first, we'll begin with the biomarkers to be used before diagnosis of prostate cancer. And the first of these I'd like to mention is the Prostate Health Index. And again, in the way of complete disclosure, I participated in the pivotal studies for FDA approval of these markers. So this is called the Prostate Health Index, and the new marker here is the -2 Pro-PSA, which is added to the free PSA and the total PSA in a mathematical model. So PSA circulates in the bloodstream in free form and in complex forms, and it's comprised of several different isoforms. For example, the BPSA is an isoform that's associated with BPH and not prostate cancer, and the Pro-PSA is an isoform that is associated with prostate cancer. And the commercial assay, the PHI assay, uses the -2 form of Pro-PSA, and this assay has been approved by the FDA. The -2 Pro-PSA is sometimes called P2, and it's been evaluated in multi-center prospective clinical trials in the United States and in Europe. And the bottom line is that it outperforms what's currently available out there, and that is the total in the free PSA. And it's also specifically associated more with high-grade prostate cancer. So in addition to being approved by the FDA in the United States, it's also approved in Europe, Asia, and Australia, and is currently in clinical use in these countries. The Pro-PSA assay has also been incorporated into multivariable risk stratification tools such as the risk calculators of the prostate cancer prevention trial, which is available online. And the formula intuitively makes sense because the higher one's PSA is and Pro-PSA and the lower one's free PSA is, the more likely the patient is to have prostate cancer. And this is just from the registration study showing the ROC curves. The black line is what one gets with PSA in the 4 to 10 range, and in this study it was in the 2 to 10 range. And the blue line at the top is the prostate health index, which gives a significantly higher discrimination between prostate cancer and benign disease. Now, if you order a PHI test, the report form gives you the total PSA value, the free PSA value, and the pro PSA value separately. So it's not just a black box calculation. It's something that clinicians are already comfortable with while they're still getting the feel for what the PHI score means. And it also will provide a summary score as well as tables at the bottom giving some summary scores of what the percentage likelihood is of having prostate cancer would be, and this is based on the results of the prospective trials that have been done. The PHI tests have been tested in men with a family history of prostate cancer. It's been tested for initial biopsies, and it's also been tested for its use on patients who possibly need repeat biopsies. And it's been studied extensively in the United States, not only in randomized clinical or in clinical trials, but in grassroots screening studies. And in addition to being studied in the United States, it's also been studied in Europe and Asia. And all of these studies have consistently shown that the PHI score is better than any of its components. As I mentioned, it's already approved by the FDA in this country, and we're basically waiting for a billing code, and my guess is that it should be commercially available within the next few months in the United States. The main FDA validation study was a multi-center clinical trial of almost 900 men. The ROC analysis showed it was best for predicting cancer, and it had, for any given sensitivity, it was more specific than either the total PSA or the free PSA. It also performed better for identifying high-grade disease, no matter what criterion of high-grade disease was used. In a subsequent study that has not yet been published, patients who are in the lowest quartile of PHI scores, which is at 25% of the population, if the PHI score was less than 27, only a single patient had high-grade disease, defined as Gleason grade 7 or higher, whereas if the patient was in the highest category of PHI scores, 43% of the patients had high-grade prostate cancer. This is a grassroots study that showed that using this in the community produced results better than the total PSA and the percent free PSA. And it has also been shown to add incremental value to multivariable risk stratification models. I mentioned the prostate cancer prevention trial model, also the nomogram that was developed by the European randomized study of prostate cancer, one model to predict an initial biopsy result and another to predict repeat biopsy results. Adding PHI to the risk calculator led to a significant increase in discrimination between cancer and benign disease. And I think that'll be probably the best use of PHI in clinical practice, is adding it as a variable to multivariable risk models. There's also some limited evidence on the use of PHI in other contexts. For example, in the Johns Hopkins active surveillance population, it was found that baseline and longitudinal measurements of PHI could predict progression of patients who are on active surveillance. And in the context of more advanced disease, because free PSA has more rapid elimination from the circulation and pro PSA is a form of free PSA, then one can detect the response to endocrine therapy earlier, and one can also predict biochemical recurrence earlier, especially patients who are more likely to have metastatic disease, and this may allow the use of chemotherapy at an earlier stage when chemotherapy may be more effective. The next test we're going to is very similar to the PHI test. It's called the 4K score, and again, it looks at